Good afternoon. I am doing a voiceover recording just to enhance your arthritis chapter 64. And this won't be anything very long. It's kind of customized the way I want you to study the arthritis content. So we're going to start with osteoarthritis. Osteoarthritis is a progressive non-inflammatory disorder of the joints. So this is not something that's systemic, and it affects whichever joints it affects. That's what's going to be affected. So when you study osteoarthritis and rheumatoid arthritis, you need to study them side by side so that you see the differences and what similarities they have. Okay, slowly progressive. We're not in this case study. I am It's the gradual loss of the cartilage. So what you get is you get extra bone growth at the joint margins, and it is not a normal part of aging. Neither of these are normal parts of aging, so you need to remember that. People feel like that's the case, but it's not. It starts at cartilage. We start losing it, people who do lose it, between the ages of 20 and 30. Most adults are affected by 40, and your symptoms come on at 50s and 60s. Okay, so it is something that's common, but it's not normal. Okay. Secondary is caused by direct damage to that joint. You fall on it and you build up this arthritis in it. The cartilage gets damaged and then you start to lose it, or it's idiopathic and we don't know where it comes from. Might be genetics. So there's a narrowing of the joint space, and between our joints in the space there's room for fluid, which helps us move and helps keep that joint mobile, and the ability to move. So anytime you have extra bone growth in the joint, there's a problem that causes pain, inflammation, and thickening of that capsule, and that cartilage is just thin, and the cartilage is there to form, to help with the joint movement. This figure really take some time and look at it, how you see the progression of how what a normal joint looks like, and then how that space starts to narrow and how we start to lose that cartilage. Very great depiction. So pain is primarily the thing that makes us go to the doctor, and it can be from mild to discomfort. Early, we just rest the joint and the pain gets better. Later, we have to rest it. We may have to take some medicine, and when it rains or the barometric pressure drops and it's going to rain or storm, people say, oh, I can tell by my knee it's going to. That's why. And the pain does contribute to disability and loss of function as it progresses. And these are the areas where you can see the pain. Stiffness occurs after periods of rest or unchanged positions. Can't sit long. You hear people say, oh, I get so stiff when I sit. And that early morning stiffness, now make a note, the early morning stiffness resolves within 30 minutes, and that distinguishes it from rheumatoid. So here's your difference. With OA, that morning stiffness will resolve within 30 minutes. With RA, that is not the case. Okay. People hear grating, and you can feel those joints popping. And when you hear people say, "Oh, it's bone on bone," you can feel it. They can actually feel it. This tells you the joints that are mostly affected. And then the deformities, Herberdines and Bouchards. And you want to look at those, and what do they mean? Your vagus is people who are bow-legged. Your varus is bow-legged. Valgus is knock-kneed. So one leg shorter than the other, hip deformity. So here are your Herberdines nodes. Those are extra articular nodes. Let me see if I can get my pointer over there. Extra growth, extra bone in these joints. Look right there. See, they're deformed because there's extra bone in the joint. And those joints are not as pliable or as mobile. Okay, when there's a systemic manifestation, you can have fatigue, fever, and organ involvement. Those things are not present It again distinguishes OA from RA. So OA is not systemic. It is local. Sorry. So that diagnostic studies, go back, we get x-rays, we get, let me see if I can move back. Look at your diagnostic studies and make sure you know how to prepare your patient, how to educate your patient, and what your expectation is. Do they need an informed consent? Is it something that's going to require a dye, or do they need to be off their metformin? So look at each diagnostic study and what are the preparatory measures as a nurse that you have to take responsibility for. Okay, there's no cure, so the care is focused on managing the symptoms, and that's palliative care, preventing the disability, maintaining and improving the joint function, and then drug therapy supplements versus treatment. So you want to rest, and you got to balance the rest and activity. So they do exercises. They do have exercises, functional positioning with splints or braces. Sometimes these people sleep in splints if it's their hands that are involved. Avoid increased stiffness by limiting immobility to less than a week. So you need to be moving it to keep it mobile. Modify activities to decrease the stress. Excuse me. Use ice or heat. Just depends. Ice for inflammation, heat for stiffness. If they're overweight, weight reduction is critical in dietary changes. Exercise, aerobic exercise, because they need increased range of motion and muscle strengthening. And when we usually recommend exercises, we use the FIT formula. FIT. That's the frequency, the intensity, and the timing. Okay. Complementary therapies, always remember non-invasive versus invasive. So there are things that are approved: acupuncture, massage, tai chi, nutritional supplements. A lot of these things are over the counter. They're not recommended, but they're not regulated either. So they're not approved by FDA. You treat according to the symptoms. Okay, mild to moderate pain, acetaminophen. There are topical agents like capsaicin cream, over-the-counter creams, and now there are some creams that used to require prescription that you can buy over the counter, like diclofenac gel. You can buy that actually over the counter now. Moderate to severe pain, and what you need to look at is this goes up in stages based on the pain. Okay, so we had mild pain previously. Now moderate to severe, we go ahead and get into a stronger NSAID like the ibuprofen, misoprostol, and there's something else that misoprostol is used for that I want you guys to tell me about in class. Arthritis, diclofenac gel, there it is. You don't want to take an oral and a topical NSAID together because that's overdosing. Your COX-2 inhibitor, Celebrex was taken off the market. It's back on now, so people use it. Steroid injections, when the medicine doesn't work and they get a acute inflammatory process, we get injections that can help with the pain and help decrease the inflammation. The disease-modifying OA drugs, we don't have any that are approved. Strontium is being evaluated, and that's a drug that is given IV injection. It's radioactive. It used to be given for prostate cancer with bone metastasis, but it's being evaluated now as a disease-modifying drug. Arthroscopic surgery, what you see normally is a progression. And I'll just use the knee because the knee is very commonly a joint where OA affects. So when they get injections, they'll get injections over a period of time, and then they fail the injections, they no longer help. Then they'll have arthroscopic surgery to try to go in and clean out some of the cartilage and kind of clean up the joint. And that may give them relief for a period of time, but they usually eventually wind up having a knee replacement or arthroplasty or hip. Nurse tell you what you see. Your acute care, your drugs, your non-drug strategies, your physical therapy, and that you need to teach your patient. Everything you do, you have to incorporate patient teaching. They need to understand what the disease is, where it comes from, what are the manifestations, how can they prevent the deformity or the disability, and what's their health promotion. What are those things? Nutrition, weight and stress management, exercise. It is localized. Let them know that it is localized. And then there are to resources. You want to adjust things at home, include the caregiver and significant others. Scatter rugs. That's one of my pet peeves. People love scatter rugs, but you trip and fall over them. Use railings and night lights. You want well-fitting support shoes, canes and walkers when they need them. And sometimes as people age, they get to a point they want to maintain their independence, so they don't really want a cane or a walker. Sometimes they're embarrassed. And then sexual counseling. They need to change their positioning in order to continue to that part of their lives. All right, rheumatoid arthritis. Remember, one thing I said is that it is systemic. It is autoimmune, and it is inflammation of those connective tissues in the synovial joints. Okay, it has periods of remission and exacerbation. Again, no cure. It is a disabling form of arthritis, and what you're going to see is it is progressive. It's systemic and progressive. So this is where our physical therapy as well as our OT people work a lot with these patients, help them make revisions in what they're doing. It affects everybody. Incidence increases with age. Again, this is not a normal part of aging. Happens 3 times in as many women as men. Remember, it's autoimmune. Genetics plays a part. And your antigens. Remember what we learned about the immunoglobulins. IgG is autoantibodies develop against abnormal IgG, and then the rheumatoid factor is elevated. So the rheumatoid factor is a indicator of inflammation, and it combines with the IgG to form all these complexes that deposit themselves on the synovial membrane. So you got extra complexes in the system that pulls out of the bloodstream and deposits themselves in those membranes or the cartilage of the joint. So then the joint recognizes that, hey, this is abnormal. So we've got to increase our inflammatory response to fight this, because the body sees it as foreign. So we go into that inflammatory process, okay? T cells, your interleukins, tumor necrosis factors, so that it's a huge inflammatory response. And this, again, good picture of the changes that we see. Look at the deformity in those feet. That's rheumatoid. The genetic further explains it makes it worse, sorry. It's a subtle onset. People are tired. They get anorexic. We see weight loss in this. Generalized stiffness because people don't feel well. They're not moving as well. Sometimes there's a precipitating stressful event, infection, exertion, childbirth, surgery, some type of emotional upset. Specific joint involvement, pain, stiffness, and limited motion. And you'll get to where you can look at people and tell, especially with their hands, if they're severely affected by rheumatoid. This stiffness, this morning stiffness is 60 minutes to several hours or longer. So they both have morning stiffness, but the OA resolves after about 30-40 minutes. This one lasts a whole lot longer. And the pain is worse with motion in this one. Affects the wrist, has progression, subluxation, muscle atrophy, and tendon destruction, walking disability, deformities in the hands. And these particular deformities are ulnar drift, swan neck, and deformity. And these are very good pictures. It's figure 64-4 of those deformities in the feet. So all body systems, remember rheumatoid is systemic. Extra-articular manifestations, Sjögren's, Felty syndrome, flexion, contractures, and flexion. So these are all the areas where you can see those changes. Your diagnostic studies, of course, you're going to do your history and physical. In that table 64-4, you want to highlight that and look at those indicators. So stage 1, synovitis, you've got inflammation in that joint. The x-ray shows that soft tissue swelling, possible osteoporosis, no joint destruction. Stage 2, you see that increased joint inflammation and gradual destruction of cartilage. 3, you've got the synovial pannus, and then the x-ray, you got extensive cartilage loss. They're starting to see it on x-ray, on plain film. And then stage 4 is that inflammatory process subsides and we lose the function of the joint. And we've got nodules. So your CBC, you're going to look at what would you anticipate, increased white count. Your ESR, that's your SED rate, active inflammation. Your CRP, which is your C-reactive protein. These are all inflammatory lab values that we look at. Your RF is a rheumatoid factor and is positive in 80% of these adults. And this anti-CCP, that's an antibody that is specific to RA. And a lot of inflammatory illnesses, they're hard to diagnose because they're not specific tests for them. But for rheumatoid arthritis, there is. The ANA is elevated. That's another factor that tells you there's an inflammatory process going on here. And then your radiologic. So your individualized treatment plan, you look at the disease activity, the joint function, the age, the sex. You know, what is their overall function? Now, the drug therapy here is really important because you're going to look at your DMARDs, disease-modifying anti-rheumatic drugs. So they're in a progressive manner, just like the disease is. So your early treatment is methotrexate. Methotrexate is also a chemotherapy drug, okay? So it has the same side effects, whether you use it for rheumatoid arthritis or if you're giving it for cancer. And the biggest side effect of most chemotherapy drugs is bone marrow suppression. When I say bone marrow suppression, the bone marrow is where the blood is made. So you're going to see a decrease in the white blood cells, the red blood cells, the platelet, all of your hemoglobin, your hematocrit, because the bone marrow is not making blood at the rate that it should. Also, it's hepatotoxic, toxicity in the liver. So you need to know what are those signs and symptoms of hepatotoxicity. We have to monitor that CBC and the blood chemistry, and we get therapeutic effects in 4 to 6 weeks. Methotrexate can be given alone, excuse me, with a biologic response modifier. A biologic response modifier is a drug that's made in a lab. It's synthetic, and it's formulated specifically for this particular disease to target the body, to help the body cure itself. Azofluridine and hydroxychloroquine, which is Plaquenil, very important to know, hydroxychloroquine. This is used for mild to moderate disease, and the acute thing to teach your patient is they have to have a baseline eye exam, and then every 6 to 12 months. If they have any change in their vision, any pain in their eye, they have to notify the physician immediately. Um, leflunomide, and then the Xeljanz. These are newer drugs that help the body again because they block that immune cell overproduction. So they kind of block that inflammatory process. In the same way with Xeljanz, that's how they work. So these are biologics or immunotherapy. They help work the body. They help the body to fight the illness. So that table 64.9 is important. Your tumor necrosis factor, again, another biologic. Enbrel is sub-Q. Influximab or Remicade is an IV infusion that we give either once a month or every 6 weeks. Humira, same thing, sub-Q, it's a monoclonal antibody. So these drugs are given in a office, usually in an outpatient setting, in an infusion center, because we have to monitor the patient because they can react to them at any time. So before they start any of these drugs, they have to have a TB test and a chest X-ray, because if they've ever had TB, it can reactivate the TB in them. So we want to be sure that they're hadn't been exposed. We want to monitor them for infection and report any bruising, bleeding, persistent fever, and they cannot get live vaccine. This is just a list of a few others that you want to be able to identify as your monoclonal antibodies and your biologics. They help the body work. See, and it tells you specifically which chemical in the body or which inflammatory factor in the body it works with. You don't have to get that specific with these drugs at this time. I want you to be able to be familiar with them and be able to recognize them. Not commonly used are immunosuppressants. And gold preparation used to be used. We used to give them actual gold, but we don't see that as much. Your steroids, of course, and injections, like I was talking about for the knees and things like that. Your NSAIDs, of course, we've gone over that for OA, same in RA. Your nutrition is important. Balanced nutrition. Pain, fatigue, and depression leads to decreased appetite. So you want to think about 6 small feedings, which are high in protein and calories, to help them because they tend to lose weight. Lower endurance and mobility, so they are unable to shop for and prepare their food. So you want to work with OT. There it is for a plan. Surgical therapy is only used to relieve severe pain and improve their function. Can have total joint replacement for RA as well, which is called an arthroplasty. Go. Most of the care is outpatient, but they're hospitalized for systemic complications or surgery. Remember, the more we can keep people out of the hospital and treated as ambulatory patients, the better they are. Excuse me. Again, hot and cold. We use heat and cold interchangeably. Pain, the cold relieves the stiffness and muscle spasms. And then moist heat can relieve that stiffness, but you should only do 20 minutes at a time. And you don't want to put a hot pack on something you just put some kind of cream on. Individualized exercise. They need recreational and therapeutic exercise. People with arthritis, whether it's OA or RA, benefit from pool, water exercise, water aerobics, because there it is. Aquatic exercise in warm water is very beneficial to them. Let's on the joints. Educate everybody, give psychological support, because remember, RA is very progressive and it usually progresses to disability. So that's coming. There is no cure. So you want to psychologically support these people. You want to make sure that you're assessing for whatever excuse me, whatever alterations they need, be it equipment or utensils or whatever. They're going to need some alterations in things with life. And it's disfiguring, so their body problems as well. It's increased in older adults, but it's a normal process of aging. Okay, I'm going to move on. I only want to enhance gout just a little. I think the students, you guys have done a great job with this chapter, but there are just a couple of things that I wanted to reiterate and to point out to you. Gout, we know, is hyperuricemia, increased uric acid. Here, our dietary measures are very, very important. We see this usually in black males. It's very common. They complain of pain in the great toe to the point where they don't even want the sheet to touch it. And that's because there are uric acid crystals that have settled in that joint. Now, it can happen in other joints, but that's commonly we see. Uric acid is excreted by the kidneys. If they can't excrete enough or too much is being made. And hyperuricemia is primarily genetic, but secondary is because of usually dietary things. What is metabolic syndrome? And I know you guys know what that is because you're in mental health right now. And those 3 characteristics of metabolic syndrome, I need you to know those, okay? Also, increased intake of high purine foods. We see that. And excessive alcohol. So a lot of times these are beer drinking, meat eating men that we see this disease in. And it hurts really bad. Sudden swelling and severe pain, and they know it because they know what they've been eating and they know what they've been drinking, and they happen and they know it's gout. Okay. Now I have seen gout in other joints. Excuse me. Had a gentleman who was very heavy, probably 300 pounds, 300 or 400 pounds, and both of his knees had gouty arthritis, and they had to surgically open his knees because the crystals and deposits were so huge. They had to get those trophy out of those knees, and because he was diabetic and his health was not good, they had to leave his knees open and they had to heal by tertiary excuse me, by tertiary intention, and we had to pack those wounds 3 times a day to keep them from getting infected. And that was just an odd thing. I've only seen it once in these 40 years, but it was quite impressive. I'll never forget it. This is gouty arthritis. See those big, huge knots. So it's different from rheumatoid. See, these are those trophi, chronic gout. In your rheumatoid, you're going to see it in all the joints. See how it's not in that finger right there? It may be starting down here, but it's not right there. So, so it can be severe, and it's dangerous because if it's systemic, it will cause kidney and urinary tract stones. Your pyelonephritis contributes to kidney disease. So the diagnostic studies, your serum uric acid that's higher than 6, your 24-hour urine for uric acid, although I've never collected a 24-hour urine for uric acid, so I don't know that that's commonly done, but it can be done. And then they will go in and aspirate some of that fluid from the joint to see, is it gout or is it something else? And then the x-ray of the affected can tell you. So your goals are to end that acute attack, and the drug therapy is important here. Your oral colchicine is an anti-inflammatory, and it's used to treat an acute attack. Okay, people with chronic gout take allopurinol. Allopurinol is for chronic, and acute is for colchicine, and they can take them both at the same time. Okay, your NSAIDs, but we're going to be careful with using NSAIDs in these patients because excuse me, they're at risk for kidney function, kidney issues, and NSAIDs, if we don't watch them very closely, can also cause kidney damage. Corticosteroids sometimes, and then ACTH, which is your hormone secreted by your pituitary. We want to prevent, in some of these people, we know we have to decrease the uric acid production, and so that's when your allopurinol or Xyloprim is used. Probenecid is also for prevention. Allopurinol is the most important drug here. It's the most common one you're going to. The uricosics can cause renal impairment, so you want to take them with food and water, and when they're on these drugs, they need to drink 2 liters a day, mostly water, okay? There are some alternate drugs you may see used, losartan and Cozar, and what are those for? Hypertension. So if a person is hypertensive and have gout, those may be the choice. So we want to limit alcohol and food high in purine. Know those foods. You know you're going to have to pick out a menu for somebody. Other thing I want to talk about is systemic lupus erythematosus. Go through. It's multi-system inflammatory autoimmune. It's very complex because there are genetic factors, hormonal factors, environmental factors, immunologic factors. So the body in itself, it affects all areas: skin, joints, membranes, pleura. It affects the heart and the lungs, the neurologic system. Debilitating. No cure. Mostly common in blacks, Asian Americans, Hispanics, and Native Americans. 90% of women ages 15 to 5. Unknown cause. Antibodies made against single and double-stranded DNA. Autoimmune reactions. They're anti-nuclear antibodies. The body attacks itself. Not sure why. It can be relatively mild to rapidly progressing, and it's very difficult to diagnose because the symptoms are multiple, because it affects all the systems, and they're general symptoms. They could be related to anything, and the way we diagnose it, the rheumatoid factor, the ANA, all those things are elevated. But it comes on subtly. It's not a big, huge thing that happens all at once. It happens over time. The classic sign is that butterfly rash that we see in 55 to 85% of the cases. And that's a very good depiction in your book of the butterfly rash across the face and the nose. Like, these are the butterfly wings, and then it comes over, and there's the butterfly. That's called the butterfly rash. It's a common symptom that we see. A lot of arthritis type deformities and symptoms. This is the swan neck deformity in the hand. We see that. Lots of different cardiopulmonary problems, and usually these people do die of secondary infection. They're on a lot of immunosuppressants. They're on and off steroids for the whole course of this. And like I said, it affects all of the body. So they either get a pneumonia or they go into congestive failure, usually, and that's what causes their death. Clinical manifestations, when you look at the systems, then you see what happens, what we see. Nervous system problems, they have a lot of arthralgias and neuropathies in their fingers and their hands, strokes, heart failure, heart MIs. The blood cells are different. We see a lot of anemia, leukopenia. The meds, they have also those side effects from the meds. Infection, they have increased susceptibility, I just said. So pneumonia is common. No live vaccines with them, especially if they're on steroids or cytotoxic. It's hard to know sometimes because it's very subtle. Your ANA is one of those indicators that we see commonly that's that's elevated in them. Drug therapy, again, we start off in stages, start off with the NSAIDs, go to the anti-malarial once we have a diagnosis of lupus. Corticosteroids, they're often on them during different times. The immunomodulators, because it affects their skin, so they have lots of different meds. And the management is monitored by serial anti-DNA titers. So that table 6416, you highlight that, and then your SED rate and your CRP, C-reactive protein. We don't want people with lupus to get pregnant. Sometimes they do, but we want them on contraceptives. Puts a lot of stress on the body and often causes serious life-threatening illnesses in them. See, every is affected. They have periods of flare, exacerbations, and periods where they're okay and can function. But your plan of care needs to include how you're going to handle those periods when they have those flare-ups. It's common in women of childbearing age, so treatment during pregnancy has to be addressed if they do get pregnant. Sometimes they are infertile, but they have lots of problems. Usually spontaneous abortion, stillbirths, intrauterine growth, retardation are common, so the baby doesn't. And if they insist on getting pregnant, we try to plan it when the disease activity is minimal. And flares are common postpartum. Lots of psychosocial issues, okay? Patient and caregiver, the SLE has good prognosis for most people, especially if it's caught very early. We do see those cases where it does progress to death. Lots of resources, and to in the direct those resources, make sure they have access to those. Okay, and that's all I have for this unit.